Hello. So this is a recording of a talk which I gave at the recently concluded MAHAPEDICON 2023. Here I shall discuss the recently published Indian screening guidelines for developmental dysplasia of hips. So the hip joint, as we all know, it is a ball and socket joint in which the ball, that is the femoral head, articulates with the socket, that is the acetabulum. DDH, or developmental dysplasia of hip, in simple terms, it is a condition in which the neonate is born with a shallow acetabulum, that is, the socket is shallow. Now, DDH can present with a spectrum of severity. We can have dysplasia, where the socket is shallow. We can have a subluxation, where the femoral head is partially out of the socket, or we can have a frank dislocation, where the femoral head is completely out of the socket. The treatment of DDH is essentially age-based. So if it is detected before the age of 6 months, usually most of these kids can be treated successfully with the Paulik harness. Between 6 to 12 months, close reduction and application of hip spica cast is required under anesthesia, and older children more than 1 year generally need surgical intervention. So as can be seen, with increasing age, the invasiveness and complexity of treatment increases, which in turn translates into poorer long-term outcomes, as long-term studies have shown. And here comes the role for screening in DDH. Most of the Western countries have implemented screening programs for DDH. Data from these countries shows that after implementation of screening programs, there is a significant decrease in late detection and thereby need for surgery in these countries. Most of the screening programs in Western countries rely on ultrasound diagnosis of DDH. In India, the problem is that it is difficult to apply the screening programs as applied in the Western countries, mainly due to lack of resources, that is ultrasonography, and lack of trained personnel, that is trained sonologists, especially in the rural and remote areas of the country. And in the absence of screening program, we still continue to see a very high disease load of late detected DDH, and therefore the rate of surgery is significantly high in our country. It is precisely against this backdrop that experts from 7 professional bodies, which included the Pediatric Orthopedic Society of India, the Indian Academy of Pediatrics, the Neonatology Forum of India, and also of radiology and gynecological bodies, they got together and they constituted an expert committee. The agenda of this committee was to formulate guidelines which would be tailor-made for the Indian scenario, keeping in mind the availability of resources and personnel in India. They were ably supported in this endeavor by the International Hip Dysplasia Institute, which is a non-profit organization based out of USA and Canada. After rounds of discussions and consultations, the Indian screening guidelines for DDH were formulated, and these were published in the August 22 issue of Indian Pediatrics. You can scan this QR code to read the full text of this article. In the next few minutes, I shall recount a few salient features of the Indian surveillance guidelines. So firstly, who should be assessed for DDH? And according to the Indian guidelines, without exception, all neonates should be assessed for DDH. Furthermore, these guidelines emphasize that the assessment should be done at multiple time points. So the assessment should be done just after the birth, as well as at all immunization and well baby clinic visits. Hence, the Indian guidelines, they are called surveillance guidelines rather than screening guidelines. The reason for recommending these multiple assessments is because it has been proven that single clinical examination can give false negative results, and many times you may miss out on positive findings, especially when the child is cranky and irritable. Also, there is an entity known as late onset dysplasia, where the hip is perfectly normal at birth, however, may turn dysplastic sometime later on in infancy. The DDH surveillance, it basically consists of 4 components, namely clinical examination, then identification of positive risk factors, selective referral for imaging, and appropriate referral to orthopedic surgeon. So let's look at these one by one. Clinical examination is probably the most important limb of the surveillance program. So every infant less than 14 weeks of age, the clinical examination should consist of ortolani and Barlow tests. These tests are basically designed to either reduce a dislocated hip back into the acetabulum or to dislocate a reduced hip out, and the examiner feels for the clunk as the femoral head passes over the edge of the socket. Due to paucity of time, it would be difficult to cover these tests in detail, but I would strongly urge you to scan this QR code and watch the YouTube videos which have been uploaded by the International Hip Dysplasia Institute in order to understand the ortolani and ball-out test in detail. In addition to these, for the older child more than 14 weeks age, the clinician should look for restricted hip abduction, the leg length discrepancy, that is one leg being shorter than the other, and in the walking age child, you should additionally look for limp. Having done the clinical examination, the clinician then notes down whether the child has any positive risk factors for DDH, and these include history of breech presentation, positive family history of DDH, and history of restrictive swaddling. Restrictive swaddling implies that the baby has been swaddled with the hips and knees in forced extension. Following this, the clinician should then do a selective referral for imaging. So the indications for referral for imaging include positive ball-out test in a child less than 6 weeks age, or presence of any of the positive risk factors for DDH, or equivocal findings on clinical examination. The imaging modality of choice for a child less than 14 weeks age is an ultrasonography of the hip joints, whereas for a child more than 14 weeks of age, it is the plain X-ray of pelvis with both hips. Referral for ultrasonography should be done only after the child is more than 6 weeks age. The reason for this is that early USG may misdiagnose a physiologically immature hip as DDH and thereby resulting in overdiagnosis and overtreatment. Finally, selective referral should be done to orthopedic surgeon. The indications for referral to orthopedic surgeon are positive ortolani test, or persistence of positive ball-out test beyond the age of 6 weeks, or presence of leg length discrepancy, restricted hip abduction, or limp in the walking age child, or DDH which is diagnosed on X-ray or ultrasonography. So to conclude, the Indian hip surveillance guidelines are easily implementable. We can easily implement them in our country with the available resources and personnel available. It is a simple 4-stage process consisting of clinical exam, assessment of risk factors, selective referral for imaging, and appropriate referral to orthopedic surgeon. And if we are successful in implementing this surveillance program successfully, it holds the promise of significantly decreasing the disease load of late detected DDH and need for surgery. Thank you.